So my name's Ruth Chalmers. I'm one of the Paediatric Allergy Dietitians from St Thomas's, and I was tasked with talking about the first year of life. So I'm going to really focus on the first 12 months of life and what we do in terms of allergy management. I will cover briefly the sort of overall allergy classification. We'll have a look at the difference between immediate and delayed. And there's always lots of confusion about what's cow's milk allergy and what's lactose intolerance, so I'll briefly touch on that. We'll review the guidelines because essentially the MAP guideline has recently been updated, and I'll highlight the changes that were made there. We'll have a look at whether there's any evidence for the use of partial hydrolyzates or extensively hydrolyzed formulas in prevention, and then talk about how they're used within cow's milk management. And then we'll look at other nutrients that you might compromise if you take dairy out of someone's diet, the effects on growth, and then just a review of complementary feeding practices, because this is a hot topic for debate right now about what we should be doing and when we should be introducing things. So just in terms of, sorry, I don't have a pointer, but in terms of the nomenclature, so essentially the overall arching term is food hypersensitivity. We have immune-mediated, which is a reproducible response on exposure, and that is then subdivided into your IgE and your non-IgE. IgE tends to be, you know, rapid onset generally within minutes, but within 2 hours of consumption of the allergen, and tends to be things that you can visibly see, so much easier to diagnose, things like hives or angioedema and swelling or, you know, immediate vomiting, and will yield positive skin prick testing or specific IgE testing, whereas your non-IgE is the one that's more less specific and much always harder to diagnose. Tends to be things, you know, occur in a more delayed fashion, sort of 2 hours plus, anything up to 72 hours after the food consumption. And tends to be things like, you know, abdominal pain, distensions, changes in stool frequency, and that can be constipation, it could be diarrhea, it could be blood and stools. And then you've got your non-immune mediated disorders, and that's where lactose intolerance comes in, because essentially that's due to an enzyme deficiency rather than an allergy to the protein, so you're not able to metabolize the milk sugar. So if you look at those in a bit more detail, like I mentioned with IgE, essentially you've got your allergen, in this case milk, being presented to an antigen-presenting cell. It's presented to a naive type T cell, and it goes on to have a Th2 response where you get IgE produced to milk, and then you get mast cell degranulation, which leads to all those immediate type symptoms. And you'll find that, you know, the history is highly suggestive. They consumed the milk straight away, they got redness or hives or itching. And the history sort of gives you your answer before you've even done your skin prick testing or blood test. Whereas with your non-IgE, the only way to prove or disprove a diagnosis essentially is to do an avoidance and then reintroduction. And there's some debate around how long we need to avoid the allergen for, and that's something that MAP have reviewed within their new guideline. Whereas in lactose, essentially, you've got normal digestion where you would take lactose, the milk sugar, into the gut. It would break it down into glucose and galactose. Whereas in lactose intolerance, you actually don't have the lactase there to be able to metabolize the lactose into glucose and galactose, and therefore it's fermented by bacteria and leads to things like, you know, gas production and loose stool. So that's the difference between the three different things. And I'm going to focus really on non-IgE mediated milk allergy. In terms of whether there is any evidence for, in high-risk families, whether we should implement partially hydrolyzed formulas or extensively hydrolyzed formulas, and I'll explain what an extensively hydrolyzed formula is just shortly, as a method of allergy prevention. This was a recent systematic review done by Bob Boyle and colleagues for the Food Standards Agency, and they found that there's no evidence actually for the use of partially hydrolyzed formulas. So formulas where they've taken milk protein and broken down the long chain proteins into smaller, shorter chains. Essentially that, you know, the evidence, there was lots of bias within the studies, and you know, in the UK we don't accept the claim that, you know, it will prevent eczema or asthma or allergic rhinitis, and we don't recommend the use of partially hydrolyzed formulas such as you know, as they may well do in Europe, or extensively hydrolyzed formulas. So if you've got a high-risk family who come to you and say, oh, I've got a child, you know, one child who's already got milk allergy, they're expecting another, ideally we want to support the family to be able to breastfeed, and if they're unable to do so, then they would go on to a standard formula like anyone else. In terms of the guidelines that are out there, I'm sure you're all familiar with them. So there's the NICE guideline, there's the British Society of Allergy and Clinical Immunology, and then the one that we'll take a more in-depth look at today, which is the new IMAP guideline, which replaces the previous MAP guideline. And what I thought I'd do is we could have a look at what the changes were to the guideline. So what prompted the change, you might ask? So essentially there was a survey of over 700 individuals. There was about 400 GPs and 300 parents. And essentially what was established was that actually, parental perception was that management, wasn't quite what they thought it should be. That, both healthcare professionals and parents felt that we needed more simplistic tools that were easier to implement. And that we needed, a logical pathway, which there was in place, but they needed some tweaks generally to incorporate feedback from healthcare professionals and parents, new research in terms of how long we should exclude dairy from someone's diet and what formulas we should use and why. And then also people weren't happy with the sugar content of the milk bladder for reintroduction, because generally they're all quite high sugar foods. And as this has been used in lots of young children, parents weren't very happy with that. So reviewing the process and making sure that it could be used nationally rather than being UK specific, because you don't get, McVitie's Digestive or malted milk biscuits in every single country. So they were going to use recipes rather than use pre-packaged foods. So this is the new fact sheet that goes along with the milk bladder, and this was really about expectation setting. So from the outset, it explains what is the difference between IG and non-IG mediated milk allergy, and so that parents understand that actually you do need to go through that period of exclusion and reintroduction, because generally what we were finding is that, if you get a symptomatic improvement by excluding the dairy from the diet, then there's, a lot of reluctance to actually put dairy back into people's diet to confirm the diagnosis. But obviously, that's the only way we can prove the concept if it's not immune-mediated in an IG format where we can test for it. So this is, essentially it's good because parents then from when they commence realise that, it's going to take at least a month until you've got a clear-cut answer, and that they need to, what the symptoms are and what the differences are. So this is the algorithm, and on the whole, this hasn't changed hugely. Essentially, it's still broken into mild to moderate non-IG milk allergy. The presentation in terms of the symptoms are the same. The thing that they did change was in terms of formula use, and this is because if it's going to be used internationally in some countries, they use soya formula as first-line formula, whereas in the UK we wouldn't use soya under 6 months of age. In other countries they do. So, and that was just so that we can make it, more of an international guideline. So that was really the only change there. In terms of the calcium and vitamin D, so essentially if you've got an exclusively breastfed child, you'd be telling the mother to go on a dairy-free diet with hopefully dietetic support, so she's able to, exclude all dairy from her diet and then appropriately replace her calcium and vitamin D intake. Historically, that's at 1,000 milligrams and 10 micrograms of vitamin D, whereas it now stays in keeping with local recommendations, and that's because obviously the maternal diets will vary in their calcium content in terms of how many alternative products parents take that are fortified. So you've got to make sure that if you're avoiding cow's milk in the maternal diet, that we adequately replace. And just to highlight what calcium requirements are during lactation, so essentially they're 1,250 milligrams a day, so it's actually really difficult to achieve even if you can have dairy. And if we take a look at some of the calcium supplements that are generally, that parents may be buying who are breastfeeding, you can see that they generally only prescribe around half the recommended intake for someone who is breastfeeding, and some much, much lower. So it's being aware that, that won't provide 100% of the reference nutrient intake, and they may either need, an additional calcium supplement on top, or, we then need to find other foods that we can use to make up that dietary shortfall. And that's similar if they go on to prescribed vitamin as well, with the exception of calcium D3, which does give the 1,000 milligrams. All the others have got a much lower calcium content. So it's just being aware of that if you're recommending the top-ups. The other thing they changed was the length of elimination. So essentially, historically, it was 2 weeks, whereas it's now gone to 4 weeks. And that was taken into account new data that suggested that we need that 4 weeks elimination period to get a clear-cut answer as to whether or not those gut symptoms improve or not. And then the other change was that if you exclude cow's milk from maternal diet, and then when you reintroduce the milk and symptoms reoccur, and then you want to exclude milk again, but this time mum maybe wants to do a combination of breastfeeding and formula feeding, then we can use an extensively hydrolyzed formula. We don't need to go to an amino acid-based formula as first line in this patient group. So they're sort of the key changes with the MAPs. In terms of what an extensively hydrolyzed formula is, essentially, you can see that milk is made of intact proteins. You've got whey proteins and casein. In a partially hydrolyzed formula, you get some enzyme degradation, but you're still left with sort of, long Daltons of protein, and patients will still react to those if they've got cow's milk allergy, whereas in extensively hydrolyzed formula, you're getting much smaller protein Daltons, usually less than 1,000 kilodaltons or 1,500 kilodaltons. And as a result of that change in terms of the chemical structure of the protein, you won't get the antibody binding and that allergic cascade happening. Whereas in amino acid-based formula, you've got essentially 3 amino acids, the single building blocks of protein. And in terms of a definition, an extensively hydrolyzed formula needs to be tolerated by 90% of cow's milk allergic patients with a 95% confidence interval. So that's what all the formulas that are out there in terms of your whey-based hydrolysates or your casein-based hydrolysates have obviously gone through trials with cow's milk allergic patients to establish that they're tolerated. In terms of the different formulas that are out there, so we've got our whey-based ones. The common ones that you'll see prescribed are Arthera, Aptamil Pepti, and Cow and Gate Pepti Junior, which is about to change its name to Aptamil Pepti Junior. And then you've got your casein-based hydrolysates, so Nutramigen, and this now has a probiotic added into it called Lactobacillus GG. There's Progestamol, and then there's Similac Alimentum. We've got amino acid-based formulas, which generally you'll see either pure amino, alpha amino, or Neocate LCP. They're the common three prescribed, and they would be used in your population not to 12 months, or you've got those for 12 months plus, where there's been the new launch of Neocate Junior, which is used usually in 12 months plus. And generally, in terms of indication for use, you won't transition onto a Neocate Junior style of formula if you're on an amino acid-based formula at 12 months, unless there's other indications such as you've got faltering growth, you've got multiple food allergies. It's not an automatic transition. Usually you'll transition, in the UK anyway, onto a calcium-enriched milk alternative. But just to clarify what the different formulas are. In terms of why they made the changes, in terms of why should we use an extensively hydrolyzed formula in those breastfed infants if they're transitioning onto formula rather than an amino acid-based formula, it was historically recommended. It's because within breast milk you can detect beta-lactoglobulin, and the concentrations in extensively hydrolyzed formula are very similar to those found in breast milk, so it should be tolerated. Obviously, if you put a child who is breastfed onto an extensively hydrolyzed formula and they are symptomatic, then that would be, indication to step them onto an amino acid-based formula. But you don't automatically have to go into an amino acid-based formula if you've been exclusively breastfed and you've got milk allergy. Like I mentioned, the other thing that's recently changed in paediatrics is about the vitamin D recommendation. So essentially, if you look on NHS choices, the guideline is that you should have 8.5 to 10 micrograms of vitamin D a day. But if you're on 500 mils of formula, that you don't need to give children vitamin D supplementation, and that all children under 5 should be on vitamin D. Whereas if you look at the Scientific Advisory and Committee of Nutrition, they recommend that all babies, and they highlight that 500 mils of formula actually won't provide sufficient vitamin D. And if you just take a look at the different extensively hydrolyzed formulas, you can see that if you give just 500 mils, so the middle column on the table highlights how much vitamin D there is in 500 mils of formula, you don't actually achieve the RNI for age, and the final column shows you how much you'd have to have. And obviously we don't want to encourage additional formula consumption just to achieve vitamin D requirements, because obviously, number one, it would compromise your intake of solids, and number two, obviously it's got huge cost implications. And whereas we'd rather you top them up with a vitamin D supplement, the common ones that you see prescribed within the that are prescribable in the NHS are your Avidec and your Dalavit, and also you get your Healthy Start drops, and they're significantly cheaper. So you could just combine the two, and the dose of vitamin D wouldn't be excessive if we did so. In terms of the reintroduction of the milk, so if it turns out that milk allergy is the diagnosis and they stay on a dairy-free diet, at some point we actually need to re-challenge these children who have delayed milk allergy to establish, have you or haven't you outgrown your milk allergy? And on your left-hand side of the screen is the old milk ladder. You can see it was a 12-step ladder, used commercially made products. And whereas the new milk ladder is only, half as many steps and uses homemade products rather than commercially made products. And that was to make it, agree with the international use. The other thing they did, these are the recipes. So they modified them, whereas the old recipes you would have to modify to make them wheat-free or egg-free if you had a multiply allergic child. The new recipes give you the option of those recipes being wheat-free or egg-free, or so we can actually use the milk ladder in children who maybe are multiply allergic. And obviously the sugar content was lowered to be in line with the World Health Organization guidelines, because that was one of the parents' biggest concerns, was that we were asking them to feed their children biscuits and cake and high sugar products. Obviously, the one problem with using homemade recipes, if you've got someone who maybe isn't, Delia Smith in the kitchen, you might need to give them a bit more support around how to implement it. But they can freeze products. Again, it's the same recommendations in terms of, starting off with a small portion, so half a biscuit or a quarter of a biscuit, waiting 48 hours or, sort of up to 72 hours, and then, increasing the dose to see what their tolerance is. You take steps up the ladder, establish where the threshold is, and then continue on steps tolerated, avoid steps above, and every sort of 3 to 6 months step back up to see if their tolerance has changed. So that part hasn't changed. So in summary, if we look at all the changes IMAP made, essentially they made quite a few changes to the algorithms in terms of what we should do and why. Obviously the key change was around which hypoallergenic formula we choose in terms of breastfed infants, in terms of making it extensively hydrolyzed rather than amino acid based. Unless they fail the extensively hydrolyzed formula. Obviously, there's the inclusion of soya formula. However, we wouldn't use it as first-line formula in the UK. And certainly, we wouldn't use it under 6 months of age. There's obviously the new ladder and the new recipes, which moves away from the commercially made products. And that now that we need local policy on vitamin D and calcium supplementation, whereas obviously before it just stipulated 1,000 milligrams and 10 micrograms. So that's something that, in terms of a local decision has to be made in your local area. And then obviously there's the tools for parents and the tool for reintroduction of formula if you want to challenge the child with cow's milk containing formula is much clearer in terms of how to increase the number of ounces of cow's milk containing formula per bottle over what time frame. It gives it in a nice table that's systematic for the parents to follow. In terms of dairy-free replacements, I'm not going to spend much time focusing on this, but obviously these are our common replacements. We have soya-based products, which obviously can be used, but you need to not have soya allergy alongside your dairy allergy. Not common in IgE-mediated cow's milk allergy to have cross-reactivity with soya, but obviously much more prevalent in your delayed type cow's milk allergy. Generally, they're fortified, they're good nutritionally in terms of protein content. You can get ones that have got higher levels of fortification, such as added iron and zinc and selenium. But obviously, we need to challenge children after 6 months to know that they are soya tolerant. And then you can use things like soya yogurt, soya desserts, soya custards. There's an increase in number of oat-based products. So things like oat custards, oat creme fraiche, oat milk. There's higher fat versions and lower fat versions. And some are and some aren't fortified with calcium. So it's something to be aware of. Just, if you recommend an oat-based creme fraiche as a yogurt, it has no calcium. Or it has calcium, whereas you recommend their custard, it doesn't have calcium. So it's knowing which products are and aren't fortified to make sure you're still achieving calcium requirements in either the maternal diet or the infant diet. There's a huge increase in coconut-based products, so things like coconut-based cheeses and yogurts and calcium. And again, there's huge variability in whether or not they are or aren't calcium enriched. So there's only one coconut yogurt that is calcium enriched, and none of the cheese-based products are. So it's just being aware of that. Pea-based products, again, commonly being used. You need to know that they don't have any pea allergy. The common products are generally yogurts and cheese-based products. Again, the calcium content of the yogurt is very low and the cheese isn't fortified at all. There's increasing use of tree nuts, mainly things like cashew, almond and hazelnut, so you obviously need to know that they don't have any tree nut allergy. Again, fortified generally with calcium in terms of milks, but any of the cheeses and yogurts aren't enriched, so things like the new Nush yogurt or the Gusto-style cheeses aren't enriched. And then you've got your gluten-free grains, things like rice. Rice milk's not recommended in children under 4.5 years of age because of the inorganic arsenic content, so it wouldn't be first-line choice for young children. And there's also an increase in things like quinoa milks and potato milks, and again, these aren't all fortified, so you need to be aware of that if you're recommending those as alternatives. Because generally, if you're recommending a milk alternative, you're doing it because you want them to get the calcium from the alternative. Always make sure that you recommend the non-organic varieties, because generally the organic varieties won't have any added calcium in them. In terms of the other factors we need to consider in children is obviously, you know, dairy in children's diets provides calories, it provides protein, it provides calcium, and if you take all the dairy out of someone's diet, you're likely to affect their growth. And this is a study looking at milk allergic children versus non-milk allergic children in the US, and what they showed is that children with milk allergy and with multiple food allergies are shorter and lighter than the non-allergic counterparts. So we do need to make sure that we're, you know, actually measuring the anthropometry of these children to see whether or not we need to consider any form of you know, supplementation in terms of food fortification, which is obviously harder to achieve if you're avoiding dairy and dairy products. And this is another study just showing, you know, similar data, essentially that if you're avoiding cow's milk at 2 years of age, you're shorter and lighter than your age-controlled counterparts, and that's those without food allergy and those with food allergy but not milk allergy, and then just milk allergic. So it's avoiding cow's milk per se that appears to have the effect on your growth. So we need to make sure that we are actually monitoring these children to see that they are still thriving in terms of getting sufficient nutrition. And that would be the one indication for keeping someone on an infant formula, you know, longer, or switching someone onto something like a follow-on amino acid-based formula. If they've got faltering growth, that would be one of the indications. There are others, but that would be one of the main ones. Then if we move on to weaning guidelines, so this is a hotly debated topic, and I'm sure you heard all about LEAP and EAT studies this morning from George. So what's happened in terms of food allergy? We all know that the prevalence of food allergy is on the increase, with about 1 to 2% of adults being affected and about 5 to 8% of children. There's been a huge increase in the last 10 to 15 years, with peanut allergy tripling and egg allergy increasing. And really the question is why has this happened? And if we have a look at what we've done in terms of weaning in the last sort of 30 years in the UK, you know, there was a sort of tendency to avoid allergen introduction and promote breastfeeding for longer and delay the introduction of solids. So you can see, if you just, you know, if we take a brief look at the sort of history of infant feeding, you can see that in the 60s that most children were actually onto solids or onto some form of complementary food introduction around 4 months of age. By the 70s, it was, you know, slowly being delayed, and it was being encouraged to breastfeed longer, more like 4 to 6 months. Then in the late 90s, essentially, we advocated that peanuts shouldn't be consumed during pregnancy or breastfeeding, and they shouldn't be introduced into children's diets until after 3 years. And then in the early 2000s, we recommended exclusive breastfeeding for the first 6 months to optimize growth. And then mid-2000s, we said, well, you can introduce solids from as early as 4 months, but, you know, ideally we want you to keep on going to 6 months with exclusive breastfeeding, and we don't want the common allergens introduced before 6 months, so that would include your milk, egg, wheat, soya, nuts and fish, and again, no peanut again until after 3 years. And then in 2009, they then withdrew that advice and said, okay, since we told you to avoid peanut during breastfeeding and pregnancy and in early weaning, we've actually increased the incidence of peanut allergy, not reduced it, and therefore, you know, we need to look at strategies to now try and reduce the levels of allergies we're seeing within our population. So in terms of, you can see that this is from the infant feeding survey, and you can see how rates have changed in terms of solid introduction, in terms of, you know, how many children were on solids by 3 months of age in the early 2000s compared to how many children were on solids by 4 months, and then 5 months, and then 6 months. And essentially what we did is we pushed the window at which solids were introduced into infants' diets by encouraging exclusive breastfeeding till 6 months, and then solids from 6 months. And there's lots of factors in terms of reasons that we've seen an increase in allergy prevalence. We're not saying that, you know, delaying the introduction of allergenic foods is obviously the sole reason. We've got things that we know about, like things like genetics, you know, family history plays a role. We've got things like ethnicity playing a role. We've got environmental factors, such as the sort of, you know, hygiene hypothesis and living on farmyards or not. We've got obviously different modes of delivery we know has a role. We've got different micronutrients that have a role in terms of things like vitamin D and fatty acids. Microbiome's a real emerging area of interest in terms of how that affects allergy. We know that if you limit the diet diversity, that affects your risk of allergy. So if you eat fewer foods, and if maybe more of the foods we eat are commercially made rather than homemade. And we know that we changed how long we breastfeed children for exclusively, and when we introduce solids. So if we look at what current UK guidelines are, so this is the current booklet you're given in the NHS for the introduction of solids. So it says from around 6 months of age, preferably alongside breastfeeding until 12 months. And then if you look at other sources, that's quite conflicting. You can see why parents end up hugely confused, because some say between 4 to 6 months, some say not before 17 weeks. And essentially when it comes to the allergenic foods, what it tells us is to introduce cow's milk, egg, wheat, gluten, nuts, peanuts, seeds, fish and shellfish one at a time in an age-appropriate form. So obviously things like nut butters, not whole nuts, you know, well-cooked egg, not loose egg, although that's now changed, and not before 6 months. And you do that in a graduated fashion. And that we don't have any evidence currently for delaying the introduction of allergenic foods. But if you've got a high-risk infant, so they're meaning someone with eczema or a family history of food allergy, that you might want to speak to your GP or health care professional before, or health visitor before introducing peanut. So if we have a look at what's actually happened in the you know, internationally, in terms of, there's been lots of studies looking at actually, if we think about early introduction, is that protective, and can we stop the rise in food allergy? And these are all the studies that have, you know, happened all around the world. Essentially, the ones that, you know, I've had dealings with is Leap and Eat, working at St Thomas's, given that they were both done at St Thomas's. And essentially, if we look at what the new feeding guidelines are going to say, they're going to focus rather on the timing of introduction of allergenic foods, move away from advice to delay the introduction of solid foods, but not explicitly say that we should introduce allergenic foods early with regards to peanut and egg. And we can have a look at why they're recommending that. So this is currently the EACI guidelines, the European guideline, and that they're saying that there's no need to avoid complementary foods beyond 4 months, and that there's no evidence to either withhold or to actively promote the introduction of allergenic foods, and it should, you know, go along with normal weaning from 4 months of age, regardless of what your atopic history is. And this is where there's lots of debates. If we look at what the current systematic review done for the Food Standards Agency and the Committee of Toxicity report found, so they said there's moderate evidence to reduce the risk of allergy with early introduction of egg and peanut, and this would be applicable to either, you know, normal or high-risk populations, so those with eczema or parents with food allergy. That we know you're more likely to react on exposure to egg, and that the timing of egg and peanut is the ones that are probably important, and there was some weak evidence around fish. But they said there was insufficient data that it should be early introduction of peanut or egg before 6 months, and that there's no evidence that early introduction of these foods, but there is no evidence that actually early introduction increases the risk of allergy to these foods. And there's reasonable data to support that peanut and egg from 6 months as part of complementary feeding practices would reduce the risk of allergy, and that's their current recommendation. And they were concerned about things like breastfeeding rates. However, if you look at the EAT study, the breastfeeding rates don't differentiate between the arm who did current guidelines in the UK or the arm who did early introduction of the 6 major allergens. They were worried about things like toxins. However, if you look nationally, there's not much evidence of this, particularly in countries where there's much higher peanut consumption. They were worried about the risk of choking, but obviously we were recommending that you still continue to avoid whole nuts until 5 years of age and use nuts in a safe form, either a nut butter or ground or something like Bamber, which is a corn-based snack covered in peanut protein. And then obviously there were concerns previously about the risk of salmonella infection. However, the recent report says that as long as it's a lion stamped egg, it should be safe even in a less well-cooked form. So in terms of what the guidelines from other countries said, essentially they said that high-risk infants should be considered for the introduction of a peanut between 4 and 11 months, and that if you've got severe eczema or egg allergy, that you should be evaluated by an allergist first. And then other countries went on to adopt different guidelines. So this is what America say. Essentially, if you've got severe eczema or egg allergy or both, you would go on to perform ideally skin prick testing or specific IgE testing. And if obviously negative, they would recommend home introduction or a supervised feed in an office. If it's positive, then there's a protocol that they would recommend you follow. With skin prick testing, if it's between 0 to 2 millimeters, so essentially negative, less than 3 millimeters, again, home introduction or a supervised feed in an office. Where if it's between 3 to 7 millimeters, they were recommending supervised feed in office. We don't tend to do supervised feeds in offices in the UK. We only do, hospital-based food challenges or supervised feeds in a ward-based environment. There's no feeding people outside offices. It's much more common practice in the US. Whereas if it was greater than 8 millimeters, then they were taking that as the accepted cut-off that actually, we'd missed the opportunity. You already had peanut allergy. In terms of the recommendations, so in infants with severe eczema or egg allergy or both, they recommend that you definitely evaluate them with some sort of specific IgE or skin prick test and then offer oral food-based challenge. And then they go with the LEAP recommendation of 2 grams of peanut protein 3 times a week, which equates to about 3 teaspoons of peanut butter or 2 packs of Bamber. And again, they're recommending between 4 to 6 months, so that earlier introduction. With mild to moderate eczema, they're recommending that you can introduce it at home in around 6 months. With no eczema or any other food allergy, you would just introduce it in the way you naturally would have done within your normal family home setup. In terms of what Australia have taken from the guidelines, essentially, the last 3 bullet points, the ones we're really interested. So they say where there's a family history of allergies and there's moderate evidence that then there's moderate evidence that introduction of cooked egg before 8 months can reduce egg allergy. So essentially, still after the 6 months, but before 8 months. Where there's good evidence that infants with severe eczema or egg allergy, then they encourage peanut consumption before 12 months because that can reduce the risk of peanut allergy. And if your child already has an egg allergy and they've already got eczema, then you should probably consult a healthcare professional before introducing peanuts safely. And then finally, what ESPGHAN says to the European guidelines, so essentially based on LEAP and EAT findings, whereas in the UK they looked at 5 randomised controlled trials. This is just based on LEAP and EAT data. They said exclusively breastfeed for 4 months, ideally continue for up to the 6 months. Common allergenic foods may be introduced alongside other foods from 4 months. And if infants at high risk of peanut allergy, so if you've got the severe eczema and the egg allergy, which are the 2 factors that LEAP picked up were factors that predispose you to peanut allergy, then ideally they want this window of opportunity between 4 to 11 months for introduction. And historically they delayed the introduction of gluten, whereas that's no longer the case. You can do it between 4 to 12 months. So you can see that weaning practices, there's still lots of debate about what we should do and when, and you can see why parents end up hugely confused. Essentially, UK weaning guidelines haven't changed. And obviously, the high-risk individual are the ones that we need to risk assess. They need to come into centres, and we're now looking at setting up something called a rapid access clinic. So essentially those children with eczema and egg allergy can have skin prick testing and, you know, a challenge on the day, because otherwise what happens is they wait so long for a food challenge that by the time they come back to us, they're ending up already sensitised and having developed, you know, peanut allergy, because they wait maybe, you know, 3 months or 4 months for the food challenge. So it'll all be done in one day. And then the key message is making sure that, you know, once you've introduced the allergen, that actually you continue with regular exposure, to make sure that then they don't have breaks with no exposure and you know, become sensitised because of that. And generally we're recommending that for peanut and for egg, because that's where we've got the strongest evidence from Leap and Eat. And obviously they need to eat sort of 3 teaspoons of peanut butter a week, or 1 small egg a week. They're the doses we're going with. So we'll have more data on how successful we've been, because that starts in January. Yeah.
Thank you very much.
Thank you.
One question only, and I think it was that lady there that had her hand up. If you just wait for the mic.
Yeah, that's fine.
It was just a quick question actually about the rapid access clinic you mentioned. Is that specifically at St Thomas's, or it's not something that you're hoping to roll out UK-wide yet? No.
Yeah, it'd just be at St Thomas's. Thank you.
Thank you very much.